thing. The student will present a case and you will take the exam, and at the same time, your opinion and your this is teaching. Not only the student, there are so many students they are listening.
Okay, sir.
So over to Ravi.
Yes, sir. I mean, just we'll wait for 1 or 2 minutes. Let the students bid 2025 join, sir. Then we'll immediately start.
So actually quite a nice way of getting more teachers teaching the students. I wish it was there in our time as well.
Nice. The good part is that the thought is all of them, but we just made it slightly more, you can tell, palatable, more acceptable to the students. Because it remains in the YouTube and they can listen times and again. All the teachers, they take the classes. It's good actually.
Yeah.
All right. So probably we can start off with 10-5, sir. With the available students, I think there'll be a couple of people more getting joined as and when we progress. So can we go ahead, sir? Can we
start? We are live. We can go ahead.
Okay. So good morning, students. We are very happy to meet you once again for this Regain program. And this is our 15th edition. And I think we have been doing it mostly on all Sundays. And thanks to our course directors, Dr. Pratik and today's moderator, Dr. Rabiranjan. It's been extremely great journey over this last 15 years, 15 issues that we have been conducting where all the students have been actively engaging. So we thank you once again for all this. And I request now Dr. Pratik to just introduce the examiner for the day, Dr. Rabiranjan, and then accordingly take it forward from here. Over to you, sir.
Yes, our this is the moderator today is Dr. Rabiranjan, and he is a very bright student of ours, and has a very good academic career, and he presently is practicing as a consultant nephrologist in the Mission Hospital, Durgapur, and he will just introduce Dr. Golay, and then our class will start.
Yes. Over to you, Dr. Rabiranjan.
Yes. Good morning, everyone. Today we are in the last episode of season 2 Regain classroom. So this was a long journey with Dr. Pratik sir, Dr. Vishal sir, and all the renowned teachers all over the country. And active participation of students has made this program success. So today our examiner will be Golay sir, and he will be taking class on probably this is going to be a CKD with some vascular access problems. The case will be presented, and later on the discussions will be on. So let's without delay start with the Golay sir. You can start with the classroom.
Just one second. I should take Dr. Golay is a very busy practitioner in Siliguri, so he just got some time to give us here in the class in this holiday. He's a brilliant academic career. This is MD he has done from IPGMER and with the post-graduation from PGI Chandigarh. After that, he did his postdoctoral course from the IPGMER with lots of national and international papers and the awards. And after that, he is a very nice person with a very good amount of knowledge and good orator. So we can expect a very good class today. Over to the student and Dr. Aniruddha Datta and Dr. Golay, please.
Thank you, sir. Sir, I will share the screen and the presentation for today. Good morning, respected teachers. Shall I start my case presentation?
Yeah, go ahead. Present.
Good morning, sir. I'm Dr. Aniruddha, and I'll be presenting the case. And my patient, Mr. Vishwajit Haldar, a 36-year-old male, Hindu by religion and a resident of Noapada, Kolkata, who was a civic volunteer by profession and currently is unemployed, educated till bachelor's in arts, was admitted in our hospital on the 20th of July and was examined on 20th of August. The informant in this case was the patient himself. He presented with the chief complaints of swelling, pain, and blackish discoloration of the right hand and the fingers for last around 2 years, dilation and the tortuosity of the veins of the AV fistula for similar duration, and bleeding from the needle prick sites of the AV fistula after removal of the needle, which was there for around the similar duration, and swelling of the entire left upper limb as well as the left side of the neck and chest for last 6 months. Now, coming to the history of the present illness, the patient is a diagnosed case of chronic kidney disease on thrice a week maintenance hemodialysis since 2019. His initial AV vascular access is the AV fistula created in the right forearm in 2015. Since 2019, he had started noticing swelling of the fingers of the right upper limb. It was It was present all throughout the day and associated with a throbbing pain, which has gradually increased in intensity and at present does not subside even with medications. There is no history of any augmentation or relief of the pain during hemodialysis. There is a swelling over the fingers which have progressed from the dorsum, fingers up to the dorsum of the hand and wrist. And also that over the time, the veins have dilated and developed serpentine tortuosities extending from the dorsum of the right hand up to the mid of the upper arm. Now, in this period, he has also noticed that there is prolonged bleeding from the needle prick sites after the removal of the needle, and that is noticed after the completion of every dialysis session, which requires extended placement of dressing. He has also noticed blackish discoloration of the tip of all the fingers in the right upper limb since about last 9 months, and he has also noticed that he has developed a small ulcer-like lesion in the right-sided index finger since last 5 to 6 months. There has been no episodes of suction or reduction of blood flow from the AV fistula, nor any episode of loss of thrill. Due to this difficulties in the right upper limb, he had followed up with a local nursing home and he got another AV fistula created in the left elbow around 6 months back. But after the creation of the AV fistula, there was a gradual swelling of the entire left upper limb, which over the 6 months have involved from the entire left side of the neck as well as the left side of the chest wall, along with appearance of venous prominences over the skin surface. And this is associated with a continuous throbbing pain and heaviness in that said limb. Due to this gross swelling of the left-sided upper limb, the fistula could never be used. So the patient's course in our hospital, with this complaints the patient had presented to us, and after the admission, a temporary dialysis catheter was inserted in his right groin, and he was told that the AV fistula both the AV fistulas won't be used for hemodialysis for the time being. He was explained about the need of or the possibility of undergoing some endovascular procedures for which he had given the consent, and he was taken up for the procedure in 2 sittings. In the first sitting, in the right upper limb, a prick was taken and through which some wires were inserted, and during the second procedure, the prick was taken and the wire insertion was done from the left wrist as well as from the right groin. He recollects during the procedure that he had intermittent feeling of warmth as well as pain in the chest and the arms, and after the procedure, he has noticed significant or definitive improvement in the pain in the limbs as well as swelling appears to be reduced. So coming to the history of the past illness of our patient, the patient was first detected to have a renal dysfunction in 2015, which was preceded by a history of detection of frothy urine since around 2013, but he never got evaluated for the same. He was also found to be hypertensive for around 1 year prior to that, and he was on a medication called amlodipine. He complained of intermittent episodes of edema in the feet, for which he was attending a local physician who used to give a tablet called Lasix, and which he recollects to cause increased urination and reduction in the swelling. In May 2015, he developed severe anorexia, nausea, vomiting, as well as severe headache, shortness of breath, for which he was admitted in a medical college, and he was told that he required urgent hemodialysis initiation, and the initial hemodialysis was done by a catheter in his groin. Subsequently, the dialysis, he was maintained on thrice a week hemodialysis by temporary dialysis catheters, which were subsequently placed in the right side as well as on the left side of his neck consecutively. After the first month on hemodialysis, he got an AV fistula created on the left wrist. But after 4 days of the surgery, he developed torrential bleeding from that particular site, and he had to be taken up for an emergency surgery for the closure of that particular AV fistula. Subsequently, he underwent a creation of a AV fistula on the right wrist, which had matured in 6 weeks, and patient continued successful hemodialysis via that AV fistula. And till the maturation, he had a temporary dialysis catheter placed in the neck, which was around 3 months from the initiation of the dialysis. So he had a residual renal function of around 700 to 800 ml and required 3 units of PRBC transfusion in the next 1 year. In 2016 October, he underwent an ABO-compatible live-related renal transplant, where his mother was the donor, who was 55 years of age at that time, and she was a non-diabetic, non-hypertensive person. And after the operation, he recollects the presence of catheters as well as drain tube in his abdomen. And in the first 2 days, he had what he recollects that he had urine output of around 5 to 6 liters per day. On post-operative day 3, he complained of increased pain in the abdomen, noticed fresh blood in the drain bag, and he was taken up for an emergency surgery. After recovering from which, he was told that there was a leak from the blood vessels of the joining his kidney. So after that incident, his urine output had drastically dropped, and he had to be reinitiated on hemodialysis. After around 2 weeks of on dialysis, his urine output started to improve, and after 3 weeks, he was taken off hemodialysis. And after a total hospital stay of 5 weeks, he was discharged. And at the time of discharge, he recollects his creatinine was somewhere 3 to 3.5, and he had a urine output of around 2 liters. Over the next 3 years, there was a progressive rise in serum creatinine, and in 2019, he again developed symptoms of nausea, vomiting, and anorexia when his serum creatinine was around 6, and he was reinitiated on hemodialysis and continued on thrice a week hemodialysis through the right-sided AV fistula. He was not sure about the possibility of a second reed transplant, so he was taken off all the 3 drugs he was taking during his post-transplant period. There is no past history of any diabetes mellitus, ischemic heart disease, TB, or there is only history of 3 units of PRBC transfusion prior to the transplant, 3 units during the re-exploration surgery, and subsequently on dialysis, only 2 units. Last 2 years, he has not required any blood transfusion. He is born out of a non-consanguineous marriage, had a vaginal delivery, no history of any perinatal complications, no history of any developmental delay with respect to age-matched peers. There is no history of any puffiness or swelling in the childhood, no history of any difficulty in micturition, straining, or dribbling during his childhood. Coming to his personal history, he's a non-smoker, had a history of social alcohol intake in the past, but he's on abstinence since last 7 years. He consumes non-vegetarian Bengali diet and has no history of any high-risk behaviors, has normal bowel movements, and has a residual renal function of around 100 to 200 ml per day at present. He has no known allergy histories. In the family history, he resides with his mother and the family of his sister, which comprises of her husband and her 2 children. His father died of cardiac causes around 5 years ago at the age of 60. No history of any similar disease in the family as well as in the first degree relatives. Coming to the socioeconomic history, at present, the brother-in-law is the sole earning member of the family, earning approximately around 20,000 rupees per month. And they live in a pakka house with 3 rooms and separate kitchen and latrine. The source of drinking water is from the municipal corporation. And the immunization history is that the patient had received all 4 doses of hepatitis B vaccine prior to transplant, along with the varicella and pneumococcal vaccine. He has also taken 2 doses of Covishield, and BCG scar was on the left hand. So to summarize my patient's history, a 34-year-old male patient post-renal transplant, end-stage kidney disease, on thrice a week maintenance hemodialysis with minimal residual renal function, with a native kidney disease, probably a chronic glomerulonephritis, and graft loss due to an ATN which progressed to CKD, presented to us with the complaint of swelling and pain with prolonged breathing from the functional right radiocephalic AV fistula, and the swelling of the left upper limb after the creation of a left-sided brachiocephalic AV fistula, possibly due to presence of stenotic lesions. Sir, shall I proceed to examination?
Yeah, I think you can proceed with the examination. Okay, we'll discuss it then.
Thank you, sir. Now coming to the examination, coming to the general examination, the patient was alert, conscious, cooperative. The apparent age corroborates with the stated chronological age, with the decubitus of the choice of the patient being sitting. He is of average build with a height of 165 centimeters, weight of 57 kgs with a BMI of 20.9. Has mild pallor, no sinuses, clubbing, icterus, pedal edema or palpable lymph nodes. Has a pulse of 92 per minute, which is regular, good in volume, felt in all 4 limbs with normal arterial wall with known radioradial or radiofemoral delay. The blood pressure is 160 millimeters of mercury measured by palpation method on bilateral dorsalis pedis. In the neck, there is superficial engorged tortuous veins visible more on the left side of the neck. Multiple old healed puncture marks are seen in both the sides of the neck. Left upper limb appears swollen from the shoulders to the hand up to the fingers, with scar marks seen near the left wrist as well as left cubital fossa. In the right upper limb, the fingers and the dorsum of the hands are swollen, blackish discoloration with on the tips of all the fingers, maximum on the index finger with one small 1 centimeter into 1 centimeter circular ulcer-like lesion in the periangular space. Scars on the radial aspect around 2 to 3 centimeters away from the wrist, which appears dilated with tortuous veins extending from the dorsum of the hand up to the arm. Presence of a curved hemodialysis catheter in the right inguinal region, which is a right femoral uncuffed hemodialysis catheter with dressing. Presence of there was a presence of IV cannula in the saphenous vein of the right ankle. Now moving to the systemic examination. In the cardiovascular examination, on inspection, left side of the anterior chest wall appears to be swollen with presence of superficial tortuous veins. Both the sides move equally with respiration with no obvious scar marks. Palpation. In palpation, the apex beat is felt in the 5th intercostal space with no heave or thrill. The veins, the tortuous veins show presence of centripetal flow. The auscultation, on auscultation, the S1, S2 are normal with no rub, no murmur. Now coming to the examination of the fistula, on the right upper limb, on inspection, a bulging scar is noticed in the radial aspect of the right forearm around 2 to 3 centimeters from the wrist, with tortuous dilated veins seen from the dorsum of the hand extending through the AV fistula site up to the arm, with multiple branchings visible, with multiple prick sites which appear to be swollen, dark and darkened. No ulceration or no exudative lesions are seen. Fingers and dorsum of the hand are swollen. No obvious hematoma is seen. On palpation, the fingers and the dorsum of the hand is warm to touch. No temperature difference between 2 limbs. A pulsatile, the dilations are pulsatile. A discontinuous thrill is felt over the veins. The thrill is felt distally over the dorsum of the hand as well as over the tortuous branches up to the elbow, after which there is a reduction in the thrill above the elbow. The pulsatile venous segments are present with nodular puncture sites up to mid of the arm. On elevation, there is no collapse of the veins. On attempting to occlusion, the thrill persists and there is no appreciable augmentation of the thrill. Now, auscultation is, there is a high-pitched bruit present on auscultation till the elbow from the anastomotic site, after which there is a reduction in the intensity. Now, coming to the left upper limb, on inspection, a swelling is noticed from the neck on the anterior aspect of the chest wall to the entirety of the length of the limb, which appears to be disproportionately swollen. Scar marks are seen in the left wrist as well as in the left cubital fossa. There is no obvious bulging or prominence in the veins are seen. No ulcerations or discolorations are seen. On palpation, the limb is warm to touch. A continuous thrill is felt from the middle of the forearm up to the shoulder which is maximum around the cubital fossa to the middle of the arm. The thrill appears to be present over a broad area. No collapse could be appreciated due to the swelling, and the flow of the superficial engorged vein around the neck was centripetal in direction. On auscultation, a presence of a soft continuous bruit was heard, which was best auscultated over the mid of the upper arm and the cubital fossa. Now, coming to the examination of the respiratory system, the upper respiratory tract is normal with trachea in the midline with resonant, which is resonant on percussion in both the sides. Breath sounds are normal vesicular breath sounds, which is auscultated over all the areas with no added sounds. In the abdominal system, on inspection, oral cavity is normal. All the quadrants of the abdomen are moving equally with respiration. Scar mark with slight swelling over the right iliac fossa is seen with palpation. On palpation, soft, non-tender, non-palpable, no palpable organomegaly is there. The margins of the graft kidney is ill-defined, but there is no presence of any tenderness. No evidence of any free fluid in the abdomen. On the parrectal examination, the patient did not give consent for that. Auscultation, the intestinal peristaltic sounds are audible. On CNS examination, the patient was conscious, alert, cooperative with normal examination of the cranial nerves with no signs of any meningeal irritation, no tremors or involuntary movements. Motor examinations, it could not be done well appreciated because there was difficulty in the flexion and extension of the fingers as well as the left upper limb due to the swelling, but the tone appears to be normal. In lower limb, the power is 5/5. The upper limb, the jerks were not examined. The jerks are normal in the lower limb, planters are bilaterally flexor, and the examination of the sensory system is normal. So this concludes my examination, sir.
Okay. So do you have anything else to tell?
Sir, no, sir, I can move to the diagnosis which I got from my examination part.
Okay. So before coming to the diagnosis, since this is purely a vascular case, so we will try to limit our discussion to the vascular things and leave CKD out of the discussion because it will take a long time, I think. So in this patient, so coming to the diagnosis, what do you think will be the diagnosis for this patient for both the upper limbs?
For both the upper limbs, sir, for the right upper limb, I feel my diagnosis would be a presence of a stenotic lesion in the outflow segment of the right radiocephalic AV fistula. And for the left upper limb, I feel that my diagnosis would be a presence of a stenotic lesion in the central vein draining the left upper limb. So the stenosis in the central vein, meaning it could be in the subclavian or the brachiocephalic trunk. Okay, and what about the ulcer on the index finger? So ulcer on the index finger, I feel it is my diagnosis would be it's because of a chronic venous congestion, venous ulceration because of a chronic venous congestion has resulted in the ulceration. Okay, so what will be the next step in the management of this patient? Next step in the management of this patient would be, sir, to after we have done a clinical examination and approached a diagnosis, my next evaluation would be by imaging modalities. The first imaging modality of choice would be a duplex ultrasound, in which I would like to look for the patency and the course of the AV fistula in both the upper limbs. Now, for the central vein part, usually the Doppler ultrasound has some limitations in terms of looking at the brachiocephalic trunk. So for that, venography via CT venography or a direct DSA or an angiography could be done for identifying the lesion in the central vein. And after the Doppler of the AV fistula, once the possible lesion is identified for quantification, the gold standard for the AV fistula also would be to do an fistulography as well as to do a fistulography. So once we have done the imaging modalities and we have identified the lesions, the subsequent management would be to go for endovascular approaches or endovascular interventions to ameliorate the particular lesions if the lesions appear to be amenable to all those sort of interventions. So endovascular therapy, for them, the standard choice of therapy would be percutaneous transluminal angioplasty or balloon angioplasties for the AV fistula as well as for the central vein. And for central vein, according to the status of the stenosis, we may or may not have to place a stent in the central vein.
So if this patient will allow you only one diagnostic modality, what diagnostic modality would you choose for this patient?
So if the patient allows me only one, then I will go for an angiography or an interventional fistulography or a venography, as because in that particular sitting I can go for the therapeutic intervention, as well as my diagnosis would be of my diagnostic accuracy would be much more compared to the routine Doppler ultrasounds.
Yeah, so exactly for any suspicion of a central vein stenosis, you should always counsel the patient for intervention right away before you go ahead for a angiography. Otherwise, it will not make sense. You give the dye to the patient. But anyway, in this patient, the patient is on dialysis. Suppose if this patient was a pre-dialysis patient who was on a dialysis wait list and he had a fistula which had shown these problems, then how do you approach the angiography in that patient?
For the patients who are yet to undergo dialysis, so one approach would be to do an MR angiography, in which we can do without introducing dyes. And if there is no availability of MR angiography for that particular patient, then the KDOQI recommendation is to use the minimum amount of dye which can be given for that particular patient to go for a gold standard therapy.
So what is the recommended dye and the amount of dye which you use for imaging of fistula? Not exactly a conventional angiography done for the proper angiography, but for the fistula angiography, what do you think should be the dye use and the amount of dye use?
So in our center, so what normally amount of dye which we require is around 10 ml of dye we usually standardly use for doing a fistulography.
What are the type of dyes? What are the type of dyes used for angiography?
So the type of dyes which are used for them, they are basically divided into iodine based dyes. So actually, they are ionic dyes and non-ionic dyes, and usually the conventional dye which is used is iohexol.
So they are divided on the basis of their osmolality, right? So
high osmolality.
You cannot use a high osmolar dye in this patient. So you have to use preferably a non-ionic dye in the minimum amount. So around 10 to 30 ml is probably enough, and even that should be used in dilution. So what is the problem in using ionic contrast in CKD patients?
Problem of using ionic contrast in CKD patients who are not on dialysis, the possibility of introducing a contrast-induced nephropathy which can push them on dialysis is always there. And also the main risk is of introducing a contrast-induced nephropathy in patients who are on a dialysis waiting list, that can push them to become a dialysis dependent patient.
So what are the mechanisms of contrast-induced nephropathy?
So mechanisms of contrast-induced nephropathy is mainly due to there is basically tubular injury due to vasoconstriction and damage of the vessels that results in a tubular injury which is mainly ischemic in nature, and then there is usually the damage manifests by around 48 to 72 hours with an average period of around 5 to 12 days. It tends to the functionality the functionality starts to improve.
That is not the definition of CIN, right? So contrast-induced AKI has a specific definition. So what is the definition of CI-AKI?
The definition I have forgotten, sir. Sorry, sir.
Okay. So how do you prevent contrast-induced AKI in a Siliguri patient, on a pre-dialysis Siliguri patient?
So the preventive strategies for contrast-induced AKI usually is basically the most accepted method is by increasing the hydration of the patient. That is the most approved therapy that prior to the procedure and post procedure, usually the patient is advised to continue on hydration, which varies from 1 to 3 ml per kg over 12 hours pre to the procedure and around 6 to 12 hours post the procedure. And also apart from that, other intervention, other drugs which may contribute to accentuate the damage, like angiotensin enzyme or the ARBs or the ACE inhibitors are withheld for that particular time period, and drugs which may increase acidotic challenge like metformin, they are withheld for that particular time period. The role of there is also definitive role of ischemic preconditioning in these patients, and also the other roles of using half normal NS and sodium bicarbonate and N-acetylcysteine, they have not proven to be significantly effective. So the main therapy is mainly hydration and the use of minimum amount of dye which is possible.
So N-acetylcysteine can be used, right? But there are some studies which show that N-acetylcysteine does help.
So they have shown to be it can be used, but the benefit is again.
So which mode of N-acetylcysteine is now acceptable? Oral or intravenous?
Intravenous N-acetylcysteine was given, but in intravenous N-acetylcysteine is advised with.
Yeah, so I think there was a study. There was a study published in JASN a few years back where they have shown that oral N-acetylcysteine is of no use. So IV has been found to be of some use. So even the data is not very conclusive. So the only thing that remains with us is probably hydration, right? With a normal saline. So the other forms of fluid also are not of use. So are there any other drugs which have been tried to prevent CI-AKI?
In other modalities of other, no, I'm not really sure, sir, about the other drugs which have been used in other calcium channel blockers, or there were
some trials with hydrostatins, isn't it? There are some trials with hydrostatins where they have used very high doses of statins, especially in cardiac cases. They have studies in cardiac patients where very high doses of atorvastatin have been found to be useful. And even the ischemic preconditioning, which you are telling, has been studied, but most of the trials are not very conclusive. So even nowadays, the whole thing about CI-AKI is also under doubt, whether it really happens or not, especially in the era of the non-ionic contrast. Okay. So do you use gadolinium in CKD patients?
In CKD patients, so the gadolinium usage was reported to be associated with nephrogenic with NSF, but the nephrogenic systemic fibrosis, but the incidence is very low. And with the newer molecules, macrocyclic molecules, the incidence is not it's not reported to be any significant usage. So NSF can be used, but again, the use of gadolinium in patients with EGFR less than 30 is again subject to the particular indication, whether the indication warrants it or not. So individualized approach is to be used. But NSF at present does not pose a much real of a threat, especially with macrocyclic gadoliniums.
Okay, so you are proposing that this patient had a right-sided mid-arm stenotic vein and left-sided proximal central stenosis, isn't it?
Yes,
so what are the reasons because of which a fistula outflow vein gets stenosed?
So fistula outflow venous stenosis, the most common cause of having a fistula venous outflow stenosis is development of neointimal hyperplasia, or the intimal hyperplasias, which are again because of presence of repeated traumas or repeated cannulation related injuries, and also they can be due to generation of thromboses as well as partial thrombi in the particular venous outflow segment, because both of them go hand in hand, the development of a thrombosis as well as development of a stenosis. And these reasons can cause venous outflow obstructions, and again these venous outflow obstructions can again contribute towards generation of aneurysmal dilations and local lesions in the vein outflow segment, which may again cause hamper the outflow segment, the flow of the venous outflow segment.
Do you think in a AV fistula, the stenosis takes place at the place where the fistula is punctured or somewhere else?
So the commonest site for generation of a fistula stenosis would be the juxta-anastomotic portion where the anastomosis has been created, or where the anastomosis has been created.
That is true for which fistula? The juxta-anastomotic stenosis is true for...
Juxta-anastomotic stenosis is most common for the radiocephalic AV fistulas or the forearm AV fistulas. So in case of upper or mid-arm AV fistulas, the commonest site of stenosis would be near the cephalic arch or the...
So the reason that you gave for trauma, usually it directly doesn't hold true for a fistula, isn't it?
Yes,
so
sir.
in which type of access does neointimal hyperplasia and direct trauma play a role in creating stenosis?
So they are the most common in case of AV vascular grafts, arteriovenous grafts. Grafts are per se the model in which they were studied.
That's what. So in fistula, the main reason for stenosis is it direct trauma or is it something else?
In AV fistula, the commonest cause would be not direct trauma. It would be it is for stenosis poor flow.
So it's mainly the turbulence, isn't it?
Turbulence, yes. The shear stress in the wall basically is the shear stress and the turbulence in the flow that results in
the loss of laminar flow is the one.
Laminar flow results in generation of the stenosis.
Okay, so you told about thrombosis, you know. So yes, does thrombosis cause stenosis, or is the other way around?
No, sir. The thrombosis is most common on stenotic lesions. It's the other way around. Means stenosis can harbinger generation of a thrombosis.
So isolated. In a stenos segment, where do you think the thrombosis will take place?
So in the stenos segment, the thrombosis most commonly take place around the neck of the stenotic lesion. I mean the
downstream or upstream?
The stenotic lesion would take place in the upstream region where there is the flow, the downstream region where the flow is less. Where the flow becomes less and more turbulent, it generates more thrombosis. It's a thrombogenic area because of the low flow and injury. And
what is the definition of decreased flow in a stenosis?
So decreased flow. So the quantified generation of the quantification for decreased flow is actually it was previously told that it is less than 300 ml per minute in a AV fistula, but now it is defined as so previously it was told as a flow which is less than 300 ml per minute on an arterial pump with suction pressure more than 250, but now it is recommended to define it in terms of any AV flow which causes that the dialysis adequacy with a predefined therapy period is where we are not able to give a adequate dialysis with that.
So it's basically more than 50% reduction above the mean arterial pressure, isn't it? So there are a lot of ways to study that. So we will come to that.
Intra-access pressure reduction more than 50% the map, yes.
Yeah. So if you have a suspicion of map reduction of more than 50% in the stenotic segment, what do you do for these fistulas? Do you just keep observing them, or you do something for these patients?
Any AV fistula or any AV graft or an access which is undergoing a reduction in the intra-access pressure of more than 50% of the map, it warrants a definitive therapy, whether it's an endovascular therapy or it warrants an intervention. Otherwise, this particular flow is in a thrombogenic range. It would either clot out or it would result in significant access recirculation, resulting in a dialysis inadequacy.
Yeah, so we do a prophylactic intervention for this patient, isn't it? Otherwise, it will result in the type of picture that you're showing on the. So, coming to the ulcer that your patient has, what are the other reasons for ulcers in the limbs in a dialysis patient?
So, causes for ulcers in the dialysis limb. In my particular patient, like the patient who has a ulceration on the distal areas of the limb, on the limb, it can be because of first and foremost, like in the case of my patient, because of a chronic venous congestion. It can be because of ischemic reasons, like in case of where there is arterial steel, or also the ulcerations can be because of presence of neuropathy, or neuropathy in which repeated traumas can give ulcerations and infections. And also on the fistula limb, over the AV fistula, ulcerations can develop whenever there is a actual aneurysmal dilation. They can be associated with superficial ulcerations and scabs, which are most commonly associated whenever there is a buttonholing cannulation technique which is followed. So because of the repeated cannulation in the same site, they can develop into ulcerations.
Okay, so what is a steel phenomenon?
So steel phenomenon is defined as the reversal of the blood flow in the distal limb, which is distal to the AV fistula anastomosis, which generates or develops into ischemic symptoms. So
why does that happen? Does that happen?
So arterial or the steel phenomenon or the ischemia in the distal limb, in the limb distal to the AV anastomosis can occur due to three particular facts. It can be because of a true steel phenomenon, or it can be because of a steel phenomenon in which the distal arterial limb, distal to the AV anastomosis has a calcification or a stenosis, or it can be because of a generalized calcification of the entire arterial limb. Coming to the true steel phenomenon is usually because of, it can be because of two factors. It can be because of a low steel or low flow steel or a high flow steel. So high flow steels are usually because of the gradual dilation of the fistula limb, which generates more amount of which generates into a much more lesser resistance or a capacitance type of vessel, so that increased amount of blood is diverted from the arterial limb to the venous axis, which results in the ischemia of the distal limb. Or it can be because of a stenotic lesion or in the pre-anastomotic access artery, which results into a low flow steel syndrome, in which, because of the lesser amount of blood coming into the AV axis, and compared to that lesser amount, more amount is shunted into the venous axis, which results in a comparative ischemia of the distal limb and generates into a steel syndrome.
Okay, so in a radiocephalic fistula, the steel takes place in the radial artery, right? So
yes,
the
sir.
patient should not be having a gangrene in any ways.
No, sir.
Okay, so why will they have a gangrene?
usually radiocephalic AV fistulas are not very prone for steel because they usually have the hand as a dual supply because of the ulnar artery. So steel is much more common for upper arm or the for upper arm AV fistulas which involve the brachial system. In case of a radial artery, if it develops, then it signifies there is narrowing or the incompetence of the ulnar arterial system.
So how do you avoid having this radial ulnar thing before making a fistula? Is there anything that you can do?
Yes, sir. So it can be done by examining the patency of the deep palmar arch. So examination of the deep palmar arch is done by an Allen's test. So the Allen's test in its physical form, it can be done by the physical examination of the hand, in which we have to ask the patient to elevate the arm and hand up to his chest level. Then we have to ask them to gradually, we have to compress both the sides, the radial and the ulnar sides, and then ask him to repeatedly clench his fist to blanch it. And then we one by one release the ulnar side as well as then the radial side and examine the nature of the flushing back of the reperfusion of the hand. If there is a more than 5-second delay in reperfusion or the flushing of the hand, then it is taken to be an incompetence of that particular side. So this examination can be again enhanced by use of digital plethysmograph or pulse oximetry. We can use to enhance the finding.
Okay. So if unfortunately, if a patient has a negative Allen's test and you go ahead and the patient still has a reperfusion problems in the limb, and you want to salvage the fistula in this patient, so what do we do for these patients?
So in these patients in which we have to salvage, we usually we do bypass graft surgeries. We can provide bypasses for the particular vessels. So the bypasses can be done by two methods, in which are known as the distal revascularization with interval ligation, or we can do a procedure known as Rudy, in which we again do a revision of the
So what do you do in a drill? What do you do in a drill procedure?
So in drill, what we do is we essentially ligate the distal portion of the drill we ligate the distal portion of the distal portion of the artery supplying, and we put in a graft from the proximal portion to a distal portion, so that the blood supplying the ischemic portion actually bypasses the AV anastomotic site. So that
what graft do you use for that?
So usually PTFE grafts or
for a traditional drill, you are supposed to use a reverse saphenous graft mainly, a natural autologous saphenous graft. And the patency tends to be better. Okay, so in this patient, how did you manage this patient now?
So this patient, as he described in his history, was managed by endovascular interventions. So in him endovascular percutaneous balloon angioplasty was done in the right upper limb, as well as I think the central venous stenosis in the left upper limb. As in case of left upper limb, there was intervention by the left upper limb as well as from the groin. So mostly a lesion in the central vein was addressed during that time.
Okay, so in the central vein, yes, only angioplasty was done, or did you do something else along with the angioplasty?
So in this patient, in this particular patient, usually endovascular intervention for a central vein may require for placement of a stent, especially if there is a venous recoil of more than 50%, or in any patient who has shown to have a restenosis within 3 months of the initial intervention. They usually mandate the presence of self-expanding stents. But for this particular patient, no stent was used, he was only he had only undergone a percutaneous balloon angioplasty, and he's currently on follow-up for further procedures.
Okay, so if this patient's left upper limb the swelling doesn't come down, if he continues to have this sort of massive swelling of the left upper limb, the right fistula is anyway probably not functional, isn't it? So
he is currently undergoing from the right AV fistula only, sir.
So this patient will have serious venous ulcers and venous gangrene in the left digits, right? So is it worthwhile in putting a stent in this patient in the right upper limb?
A stent in the right upper limb for AV fistulas, usually stent for AV fistula, stent is usually done whenever there is increased chance of there is a stent restenosis, or if there is any rupture of the venous segment, or if there is an aneurysmal segment in which a covered stent can be placed. So for him, I would rather place a stent in the central vein of the left upper limb, and then look for a better outcome from the left side.
So is it advisable to continue dialysis from the right side?
For the right hand side, no, sir, as because there has been multiple collaterals have developed, as well as the patient may, if the looks of the dilation, as because there is a development of venous lesions also. So continuation or keeping this particular venous access, this hemodialysis access may threaten the limb itself. So it would be advisable to ameliorate the venous hypertension, and then probably not use it for further channels, and look forward towards salvaging the left brachiocephalic AV fistula for him.
So in this patient, will you go and give a call to the CTVS surgeon who has made this fistula for some reasons for managing this patient?
Yes, I would definitely give him a call that for the left AV, for the surgeon who had made the AV fistula on the left hand side, then he should have undergone, or he could have done a left-sided venography for looking at the patency of the left-sided subclavian veins before creating the left AV fistula, or also for probably once the left AV fistula is in a much more amenable state, for ligation of the AV fistula in the right upper limb.
So he should also be asked for the type of fistula he has made in the right wrist, isn't it?
Yes,
whether it was which type of fistula will cause more of venous hypertension and
so any side to side anastomosis or an end artery to side of vein anastomosis, like in radar, would cause more venous hypertension.
It is quite likely that this patient might have a side to side anastomosis, isn't it? So in this patient, we can probably call him and tell him to ligate off the distal outflow vein, isn't it? Yes. That might be of some help to this patient. If you are not able to continue dialysis in this patient, probably you will not be able to continue dialysis in this patient, isn't it? So what are the options left for you?
So the options which are left for me is, one option is that I can evaluate the right-sided central veins. If the patient is very keen on continuing hemodialysis, then one option is to put a transcutaneous tunnel catheter in the right-sided cephalic vein, right-sided internal jugular if it is patent. But the more prudent option would be to advise him to undergo peritoneal dialysis, so that the vessels can be first managed and salvaged in both the upper limbs, then plan for other, if they can be salvaged, then plan for other accesses. But interim peritoneal dialysis would be most prudent for him.
Okay. Putting in a right-sided tunnel catheter is going to be risky for this patient, isn't it?
Yes, sir.
What complication might the patient have if you put in a long indwelling catheter for this patient on the right side?
So it will harbinger more stenosis in the right side, because there is already a stenosed left-sided brachiocephalic. So if we put in, there can be an underlying stenosis in the the underlying subclinical stenosis in the right-sided IJV or the right subclavian, and if we put in a tunneled catheter in that particular site, it may compromise the venous drainage and he may generate a SVC syndrome-like picture.
Exactly. So if this patient is not willing for a CEPD as well, okay, he doesn't have options for a transplant. So we don't have many options left, right?
Then other alternative alternative accesses can be tried if he is willing to undertake the risk, like a translumbar or a transhepatic access can be done, or even a femoral perm-cath can be, femoral tunnel catheter can be used. But their longevity, again, he has to be counseled regarding their longevity is questionable, and they can have increased amount of infection if hygiene and everything is not maintained.
Mm-hmm. So is there any way you can put a graft in the upper part of the body in this patient?
In this patient, we can put a graft in the upper limb. I mean, we can have loop grafts in the arm, the loop PTFE grafts or straight grafts in the arm. If from the brachial artery to the cephalic, brachial to the cephalic portion, he can be given.
What is a necklace graft?
What is a?
What is a necklace graft?
Sorry, sir, I'm not aware of necklace grafts.
So you can put a long graft from the left axillary artery to the right side axillary vein, right? So it goes around the neck this way. So that looks like a necklace. So you can close off the left-sided upper limb fistula so that the venous swelling goes down. Okay, you can close down the right side fistula as well, so that the venous pressure comes down, and then you can put a graft from the left axillary artery if the artery is patent to the left-sided axillary vein. So it will be in the chest wall and it looks like a necklace. So that is one way in which you can eventually manage. Okay, so if the site of the stenosis in the left side is in the subclavian, suppose not in the brachiocephalic, not proximally, then you can even put a left-sided axillary artery to internal jugular vein straight grafts on the left side of the neck. So those things have been tried. And desperate things will be the translumbar, IVC, tunnel catheters and all. So probably I think CAPD will be the best option for your patient. Okay, so some sort of relationships can be drawn from the fact that he had a ATN immediately post-transplant to the fact that he might have a severe atherosclerotic burden. No? It might have, the initial surgery might have gone wrong because of failure to identify severe atherosclerotic arteries, and because of which all his there is a failure of all the fistulas all over the place. Okay, so once you have a fistula, not in this patient, once you have a fistula and you are a dialysis in charge, how will you monitor fistula in a patient? What are the ways in which you can detect the development of problems in your patient?
So the fistula monitoring in our patients, first of all, the foremost thing is to do a physical examination of that particular fistula. To elaborate the physical examination of the AV fistulas, we have to look for the nature of the pulse on the AV fistula, what is the quality of the pulse, and then we have to look for the thrill of the AV fistula, and then we auscultate the AV fistula. We do a pulse augmentation test for that particular AV fistula, and we look for any presence of collaterals and other branches for that particular AV fistula. Apart from the physical examination, the other things which can indirectly give us an evidence of the AV fistula is by certain factors which can be checked in the dialysis machine. Via the dialysis machine, what we can measure is one is the ionic dialysence that can reflect the clearance of the particular AV fistula or the presence of any recirculation in that. We can also look at the venous access pressure. Increasing trend of the venous access pressure signifies a presence of an outflow stenotic lesion. And also, apart from that, we can look for presence of access recirculation, or especially if we can do periodic intra-access blood flow monitoring can also be done. So presence of blood flow less than 300 without generating access recirculations may also raise suspicion of having stenotic lesions. And also we can do imaging based modalities or ultrasounds which can be available on bedside. They can be used for monitoring of the AV fistula in the dialysis ward.
How do you monitor these patients on the bedside when you are on rounds in a dialysis round?
So bedside monitoring, yes,
you are
on
not having
dialysis
for monitoring, and you don't have any Doppler transducers and ultrasound, all those things. So you are on dialysis rounds.
So the clinically, one part is the examination. Second part is what we get during the cannulation of the particular AV fistulas. Whether usually what happens that if there is a stenotic lesion during cannulation, there is the backsplash or the wetting is increased, or if there is an inflow stenosis for a particular AV fistula, the cannulation becomes more and more difficult. And also after the removal of the cannulae in patients having outflow stenosis, there can be a presence of increased bleeding up to more than 20 minutes of bleeding from the particular cannulation removal site should indicate about the presence of a stenosis in outflow stenosis in a patient of this. And also for inflow stenosis, if a patient is undergoing dialysis and if the machine is giving repeated suction alarms, or if there is presence of suction of clots, they give increased suspicion of an inflow stenosis and or presence of any thrombosis in the venous in the AV fistula segment.
Okay, you just tell them to raise their hand, right, in the bedside.
And raising the hand, and if there is a collapse of the AV fistula.
Okay, normally it should collapse.
Yes, sir.
Okay, and you told about the augmentation test, isn't it?
Yes.
So augmentation test is used for number one, finding out stenosis and
stenosis and other accessory.
Yes, so the accessory veins.
Yes, sir.
Okay, so accessory veins. So you can call the surgeon and tell them to clip off the accessory vein if the flow is not going well. Okay. So I think we have asked you a lot of questions. So are we up on time, moderator?
Yes, we have time. If you want to ask, you can ask. Otherwise.
Okay, I'll just ask a few more questions then, since I'm getting to ask questions after a long time. So what do you think is the success of doing an endovascular procedure? Do you think you should explain the patient about the success and outcomes and a few percentages on what the patient can expect once you do an endovascular procedure in a fistula patient?
So the percentage of success is, again, the patient has to be counseled regarding this particular facts that regarding the possible outcomes. Though the success rate is again variable because of in presence of AV fistula stenosis or central venous stenosis in which stent placements have not been done, they have a variable success rate, which again, sir, I'm not very sure about the numbers, but vary from 30 to 60% in between different centers, because of they have a by 6 months there is a high chance of recurrence of the particular stenosis, especially if the patient has a central venous stenosis undergoing a balloon angioplasty, harbingers or invites a faster or a accelerated neointimal hyperplasia and resulting in a possibility of a restenosis developing very quickly. So he needs to be made aware of that particular fact.
So the patient has to be counseled, right? So simple rule of the thumb is that half of the stenos fistulas will close by 6 months, and only a quarter of them will survive in grafts in 6 months. So the failure rate is quite high, and most of the procedures are quite expensive. So in a low cost setting, in a developing country setting, if the patient has a distal fistula and there is some stenosis, sometimes it is worthwhile to close it off and create a new fistula that becomes cheaper for this patient. So cost factor and need for multiple endovascular procedures has to be always counseled, because in the excitement of doing endovascular procedure, you end up spending a lot of money for this patient. Like some of our patients probably having if you put on a long stent in the proximal segment, the cost goes up to lakhs. So some of these patients can in fact undergo transplant at that rate in a government center rather than undergoing all these difficult procedures. So that has to be figured when you're practicing in a peripheral center or in a low cost setting. And okay, what else will I ask you now? So if you have a Doppler on the bedside in your center, so what are the things that you can do with a Doppler bedside in a dialysis unit when you are a dialysis in charge? What are the uses of Doppler in a dialysis unit?
So, uses of a Doppler in dialysis unit is basically means for they can be used for certain intervention based procedures, because usually all the we can use the ultrasound for as a guidance, and we can use basically the Doppler for measuring the for having an idea about the flow volume of the intra-access flow volumes can be measured by the again it has operator dependency in that, but again also we can use them to find out the possible areas of the stenotic lesions, because around the stenotic lesions, looking at the flow velocity or the change in the flow velocity, we can identify the possible stenotic lesions. One particular aspect of it is to identify high flow volume or a high flow AV fistulas, which again have their own internal risk factors. So for a AV fistula undergoing any kind of intervention of which may result in subsequent increase in that particular velocity of the AV fistula, we should keep in mind of we should always have a pre and post intervention velocity assessment, so that the increment in the velocity is not resulting in a generation of a high flow AV fistula, which may again accentuate heart failure in that particular patient. So that is one part.
Simple term is turbulence, isn't it? So there's
turbulence.
So if you put in a color mode in the Doppler and you just keep inching up, then if you find some segment where there is increased turbulence and the color flow is disrupted, so probably that's the way you can find out initial stenosis. So how do you use Doppler in patients who are you are putting up this patient for creation of a fistula, and you are given a responsibility of doing a Doppler if you are an interventional nephrologist. So you should be able to do Doppler, isn't it, for an intervention nephrologist? So if you're planning a fistula for a patient, what are the few numbers that you should know when you are using Doppler?
So the numbers are basically so when I'm looking for a preoperative venous assessment of venous and arterial system assessment of a particular limb for a particular patient, basically our assessment is to look at the size of the particular vessel. So previous guidelines used to mention that a venous size of more than 2.5 mm and an arterial size of 2 mm is normally considered to be adequate for having having a successful or possibility of a successful AV fistula. In the recent 2019 KDOQI guideline, they have brought the number down to 2 mm. Any vessel having a diameter more than 2 mm can be considered for taking up into a creation of an AV fistula. And also that we have to look for the nature of the waveform of the pulse in the particular artery. If the artery is of a pristine condition, then usually they have a triphasic flow. So a triphasic or a biphasic flow in an artery shows the pristine nature of the particular artery, and they can be considered for creation of an AV fistula. Artery which is already having pre-stenotic lesions or having high atheromatous burden, or a presence of a peripheral vascular disease in which maybe a monophasic flow is seen, or it is there, they are not an appropriate candidate. They would not be an appropriate candidate for doing a AV fistula. And also for the vein, we have to look for the nature of the color filling in the particular vessels. If they have a wall-to-wall color filling in them, presence of any previous lesions because of any kind of damage or surgical injuries or any traumas can again hamper that. and also a complete mapping of the particular vessels all throughout is warranted to look. It is warranted so that we can look up to the neck, up to the extent of the subclavian veins, whether any presence of, to the extent possible, we have to look for any presence of central venous stenosis or any stenotic lesions in the much more downstream vessels. And also once we are evaluating, we have to look for the presence of competent perforators. So the looking for the competent perforators have implication in terms of endovascular creation of AV fistulas, and also we have to when we consider other upper arm AV fistulas like fistulas using the perforator veins, and also we have to look for the depth or the place where the artery and the vein are the most proximal. They may have implications whether the surgery can be done in a single go or whether a transposition is required or not. And also we look for the depth from the skin for the particular vessel. Minimum these aspects once the vessels are maturing. So previously a rule of 6 was followed, in which it was given that once a fistula surgery has been done, then the vessel having a more than 6 mm diameter, having a less than 6 mm depth, having a flow more than 600 ml, after 6 weeks of creation would be taken as a matured AV fistula. Now it is brought down to that at around 4 weeks of creation of an AV fistula, having a vessel diameter somewhere around 4 to 5 mm with a flow more than 500 ml. 500 ml would warrant a possibly successful use of that particular AV fistula.
Okay,
So,
so the length of 6 centimeters is also one of the 6, isn't it?
Yes,
so,
and 6 centimeter lengths for the cannulation, a straight segment of 6 centimeters.
Straight segment without any
kink or.
So, what is a hyperemic response when you are doing a Doppler? Do you know anything about that?
So hyperemic responses are in which basically it is a augmentation of that particular venous dilation, in which it can be done by movement of the hands, in which we do clenching, increase the venous return. We can do it by a tourniquet, binding a tourniquet and looking at the venous dilation. A dilation of more than 50% shows the distensibility of the particular vein, and it has a good prognostic indication for a creation of an AV fistula or a AV maturation. And it can also be mimicked by exposing the arm to warm water. That may generate a hyperemic response.
So ideally, the hyperemic response is seen for the arterial system, right? When you tell the patient to clench the fist, and when you release it and do the arterial Doppler, then the triphasic changes to biphasic. Right. So that shows that the artery is compliant and there is not much arteriosclerosis, and the success of the arterial stenosis being developing is the chances goes down. Okay, so these are the things actually you should take care when you are advising these patients for fistula, and because of that you will not land in trouble. I think we have covered most of the AV fistula graft related queries in your patient, and you've done a good job. So I think we can stop the discussion. If Dr. Pratik would like to ask any more questions, then it'll be good.
Basically, it's a very good session. Actually, we have learned many things. Actually, in every class we learn many things from the examiners as well as the examinees. So, yes, am I audible?
Yes, sir, you're audible.
So, yes, at the end, my job is to just summarize the things. Dr. Aniruddha presented a case of a post-transplant failure with multiple access problem. One side there is a proximal stenosis, other side there is a venous hypertension. And he has described these clinical features as a history and the examination very nicely. So, your examiner has directly asked you what about the management, particularly what are the investigation you should do and management. And if you are given one diagnostic modality, because in our country you cannot do everything to every patient, so what test will you do? If this is a pre-dialysis patient, then what would have been your choice? And this is for imaging AV fistula. What is the nature and the amount of the this is a contrast use that he has asked specifically what is the guideline, what is the safe zone. and what is the type of contrast you use in the angiography. And you should know more about these different types of the contrast because it is helpful in day-to-day practice, the osmolality, ionization, etc. And he has asked the 10 to 30 ml like that is maybe sufficient. And this is what is the problem of using contrast in CKD patients. This is very important because you have referred many a times with the creatinine 3, 4, and you were asked to run contrast-induced studies. And he has asked you the mechanism of contrast-induced nephropathy and the definition of contrast-induced nephropathy and AKI, and how can you prevent that? What is the recent recommendations for the N-acetylcysteine? And he has quoted for a recent publication from JSN or the oral or IV one. And the drugs that can prevent AKI, especially this is important for the cardiologists when they're doing angiography, use of high dose statins, they have a cardioprotective effect. And he has asked the stake of the gadolinium. This is in the era of MRI. This is very important again for the CKD patients. And these are the diagnostic part he has asked, and he asked about the also mechanism also the cause of this is outflow obstruction in these patients. There is any chance of stenosis on the puncture site or not? What is the possibility of juxta anastomotic stenosis, and why this is important? Which type of fistula is more important? And in this case, is a neointimal hyperplasia or a trauma or repeated puncture that can cause the stenosis or not, and with neointimal hyperplasia is more of a problem of a graft. And in these patients, she has asked why this without any trauma can anything happen to these patients, and maybe a loss of laminar flow and repeated injury that can cause the damage. And this is another important question that we often face in our practice is whether thrombosis fast or stenosis fast, and why there's a thrombosis is dangerous for the stenotic site, and this is decreased flow in the stenotic site with the definition. And he has also asked you, just I'm summarizing for your future, if there is what happens if there is more than 50% reduction in the mean arterial pressure, you observe or you intervene, and what should you do a prophylactic intervention or not? What may be the causes of ulcers in a patient with having an AV fistula, and you have described as the steel phenomenon, and why do they happen? Why there is a gangrenous site in where there is a gangrene in radiocephalic, because it is not very common to get a gangrene in a radiocephalic fistula. So before doing an fistula assessment, we commonly don't do what are the things you should do, and he has asked in this patient particularly to salvage the limb. What should you do? Will you continue this dialysis in these patients, or will you shift to other modalities? And he has also asked you about the drill procedure, which is applicable for this patient or not, and the type of the graft to be used. And this is the yes, if there is a patient is having a left upper limb swelling persist, even then what will you do? And this is the hemodialysis on the right side is advisable for these patients because he is having a significant problem in that. And will you ask your cardiovascular surgeon what is the situation? You will ask for the cardiovascular surgeons to get the history, what type of fistula they have done, is the end to side or a side to side one. And if you cannot control continuous hemodialysis, what is the next? And why putting a right-sided tunnel catheter may be a more problem in this patient because it can, if rightly told, it can precipitate this busy syndrome. So can you put a graft in the upper part of the body? You should listen the question carefully, not in the limb. He has asked for the upper part and nicely described the necklace graft that is practicing more and more nowadays. And this is very fashionable for these surgeons who do it. They, in every seminar, you will get them show this necklace type of graft. Could CAPD be good options for these patients, especially with the history of a post-renal transplant re-explorations and bleeding? And not in this patient, how do you monitor in a AV fistula in a blade side as a clinician, because you don't have the facilities all the time. And this is will you ask the patient to do some procedure like elevation of the arm? Will you do the augmentation tests or not? And your endovascular procedures are very fascinating, but you should counsel the patient. He has asked what is the success rate. It may be less than 25% at the end, and by that time you can do a new AV fistula or do a transplant in a low cost setting. So as if your Doppler machine in your dialysis unit, and you can do a Doppler bedside, what are the things you should look for? if you are not a professional one, if your training is not much, you can look for the turbulence at least. But if you are expert in endovascular procedure, in these cases you can do a complete Doppler, and in that cases you should know the this is the arithmetics or the numbers. And ask for you what is the hyperemic response for the arterial system and what does it indicate, and by this he concluded the session, because it's an excellent discussion of the patients with a vascular failure, and your performance, in my opinion, also is extremely good. Just one suggestion: your examiners are much more older than you, so if you know a thing in detail, just in very first situation, you give a crisp answer, smaller one. Don't go into the detail of every points, because in this case they lose the concentration and you may not be judged properly. Because it is your comfortable zone, you can invite through 2-3 more questions so that you get more numbers. Okay, this will give a summary and heading, then discuss the detailed part like that, so that the answer should be short and brief, and more of that you will not get much time in the examination. So overall, this is an excellent experience, and for Dr. Golay, it's our pleasure to get you in our meeting. And it's a ritual that we ask the examiner to rate the student how he did in the examination, and what is your opinion?
Yeah, it's my honor to be a part of this program, especially with our senior Dr. Pratik. So as he had suggested the last point to the examinee, so since this is a trick of answering exams, like if you note some topic thoroughly, then do not answer it completely. You just answer up to the point and just tell a one-liner answer, so that the examiner will start asking more and more questions on that topic. So he will be pulled into asking questions on that particular topic where you are quite adept at, and you tend to answer more number of questions, and because of that the chances of getting higher marks increases. Otherwise, he will not listen to half of your answer and he will immediately switch to some other topic, and you might be in a trap in that topic. So I think that is a good trick that we all used to follow. So you have done a good job. You have read quite well, and considering the fact that you are probably in second year, right?
Just completing.
So, yeah. So you have done a good job. So I would, out of 100, I would rate you 70, 75 for now. Okay. So I think complete grading would take place if you dwell into transplant, and it was a failure transplant. So a lot of other questions were there. So I would have given you more marks if we had time to discuss into all those questions. So this 70 to 75 is not for the fact that you have performed badly, but there were a lot of scope for asking more questions. So you have done a good job, and all the best for the future. You still have 1 year to go, and I'm sure you'll do well. So thank you, sir, for inviting me for this session. I look forward to more sessions in the future, because
yes.
Thank you.
Sir, I think sorry, sir, Pratik bhai, sir, you want to say something?
Yes. So over to you. Just it was our last session probably in this this group in this year's class, and wishing you a happy puja to everybody.
Yes.
Thank you.
So over to you.
Yeah. So thank you, sir. I think it's a great honor to have Dr. Vishal Golay, sir, with us today, for sparing his time. As Pratik bhai already mentioned, he's kind of so busy in your daily practice, and very difficult to get few minutes of your time. But still you could spare with us almost 1.5 hours of your Sunday, and do a qualitative job of examining the student. So thank you very much, sir, for wholeheartedly on behalf of Micro Labs. I also take this opportunity to thank Dr. Aniruddha that also for his time, and also all the students. I think it has been an exciting journey of more than 15, 16 editions of the season 2. And thank you very much for all the students who have been encouragingly participating and trying to help us to disseminate the knowledge. I also respectfully thank Dr. Pratik bhai as well as Dr. Rabiranjan, who also played a bigger role during the COVID time. They were really issues for the students to get themselves appeared and preparing for the exam. So we did a nice idea of getting all of them on online. Dr. Rabiranjan sir really helped us in getting this ASK questions over this one, and it was really helpful for many of the students. So thank you very much, sir, for that. And not the least, Dr. Pratik Bhai, I think you have been really a sole inspiration for all of us. Been consistently spending all your Sundays with us and trying to do this program to the fullest participation. So today being the last edition of this particular season, so I would wholeheartedly express my gratitude to all the examiners who have been part of this entire program, the students who have really made a big difference to this particular program, and we will schedule our next edition sooner with the next course director and as early as possible, and then we will once again connect with all the students with this regain program. So thank you very much one and all, and I wish you all in advance to a very happy Durga Puja to Dr. Vishal ji, Dr. Pratik Bhai, as well as Dr. Aniruddha and all the students, and have a great year ahead. Thank you.
Bye.
Bye, sir.
Thank you, sir.
Thank you.
Thank you, Pratik sir. Thank you, Dr. Vishal.
Thanks, Vijay.
Happy
Kuntal,
Dasara.
all of you. Thank you. Thank you, sir.